Good afternoon, everyone, and I truly applaud you for being here despite these long talks and everything else. So if anyone does want coffee, be my guest, go grab it, and then come back in. So guys, can I start?
Yes.
Okay. All right, so my topic was double and triple lumen catheters. And so I kind of generalized it a little bit because I think that was more appropriate. So we're just going to talk about microcatheters. So fundamentally, right, if you don't have a wire across, you're not going to be able to do PCI. Likewise with CTO PCI, you have to get a wire across and typically a microcatheter across before you can do CTO PCI. And of course, as we take on more complex work, such as your antegrade dissection, reentry, retrograde, etc., you're going to end up using more and more microcatheters. So first, let's understand what microcatheters do, and also we should understand what do you want it to do, right? And you kind of have to marry the task to the property for you to achieve good success. Now, let's take a special kind of microcatheter, which is a dual lumen microcatheter. So typically, these come under the umbrella. You could use it for a couple of niche indications. Number one, parallel wiring. Let's say your first wire is subintimal, and now you want to get to the true lumen distally. You will typically want to stick a second wire. Many times, using a dual lumen catheter is helpful. Wiring a difficult side branch. It does not have to be a CTO. So there are many times where you have difficulty entering a side branch because of the angulation, because of the takeoff, whatever. Using a dual lumen catheter is very helpful. Sometimes you have an impenetrable side branch occlusion. So when you look at your penetrative force, using a dual lumen catheter, and bench studies have shown that you get almost 4 times the penetration than with a straight microcatheter. And of course, there are a lot of other niche indications, such as your reverse wire technique and blah blah blah, etc. How much time do I have, guys? Where is it? Oh, I can speak, I guess. No timer. Okay, good. So there are a couple of companies that make dual lumen catheters. In India, and I'm not sure about Bangladesh, in India the only available dual lumen catheter right now is the Crusade by Kaneka. But out in the the rest of the world, and I'm not sure about Bangladesh. Do you guys have Sasuke yet? Okay, good. So they say that, so you guys are ahead of us in that. I would say Sasuke is great. Twin pass torque, etc. are basically vascular solutions companies, which is now Teleflex. These are also great products, but so when I'm in the US, I get to play with it, not in India. You have Enhancer from IMDS. There are subtle differences in each of these. In the interest of time, I'm not going to get into this. But I think Sasuke is a great dual lumen microcatheter. If you have it, use it. When you need it, right? So, lots of companies. And this is what I was trying to tell you. Your push force is going to be a lot more when you use a dual lumen catheter than when you don't. So, I'm just going to switch gears and quickly talk to you about, just show you 2 cases and 2 different indications of using dual lumen catheters. So this was a case from a couple of years ago, actually, where there was a patent graft to the circ, there was a failed lima to the LAD, so much for lima never failing, right? So the native LAD had to be open, and you can see at the very end, there's a long LAD CTO segment. And so the options really were, I wasn't going to try and wire this, I was going to try and do ADR, because the distal landing zone was okay. And if I were to go retrograde, I would have to go through that OM graft, which is the last remaining graft, and then take an epicardial collateral. Post-bypass patients, epicardial collateral always makes me cringe because bad things can happen. So you don't want to do it unless you really have to do it. So anyways, started off antegrade, and as you can see, I quickly went into knuckle. You're dealing with a post-bypass, calcific, long, tortuous vessel. So, trying to wire this is an act of futility. So, essentially, knuckle, and you do notice that that vessel there in the middle is kind of tented, primarily because that's probably where the lima anastomosis once upon a time was. So you just see me push. There's nothing great about it. Push really hard, get the microcatheter, keep pushing, and then you'll see it go. I mean, this part is boring, so I'll just cut to the chase. So I got here and I thought, okay, great, I'm in a good position. I'm just going to bring my Stingray down here and do it. But this was in another hospital. And then they told me that Stingray wasn't available, although it was during one of the Boston workshops. But anyways, lo and behold, that's the situation. Now I'm knee deep in, I got a miracle there all set up. So at this point said, okay, let's fall back to our training, which is you still have other options. So this is actually a Sasuke that was left by one of the Japanese proctors. So we ended up using that, and you can see that the second wire, which is a Confiance or Conquest Pro 12, getting into the LAD, confirm position, exchange for a workhorse wire through a microcatheter, and this was kind of the final result. Admittedly, there aren't a lot of diagonals, but it never was to start with. So it is hard to perform re-entry with the dual lumen catheter, but it certainly is possible. Now, this is another case where I just want to show you reverse wiring. And this is not a CTO. But anyways, as you can see, distal left main calcific, no surgery. So drill, we just talked about calcium, so I won't bore you with that. All this is done. So now really it's about dual lumen catheters. So what are we looking for is that you have a couple of options, right? You can use a dual lumen catheter, you can use a supercross, which is an angulated microcatheter, or you can use reverse guide wire with a dual lumen catheter. So essentially that is what was done. And on the left you can kind of see how the tip is made, and conceptually, you know, you'll just see it go. You've prepared it enough, and once the wire is in the circ, oh God, I'm really running short of time. Okay. Yeah, I mean, the rest was just a bifurcation stent, so I'll just kind of cut to the chase and show you that. So you could definitely use it for reverse wiring. I think doing it with dual lumen catheter makes it really easy. So I'll just kind of, yeah, there goes back to the 10 square millimeters. Now, a few other niche things. So you could, and this is for the big boys and probably Dr. Kaiser and a few of the other CTO folks that are hardcore here. So sometimes you have the distal cap at a bifurcation. You can take a Sasuke retrograde and then really use it for penetration if you're dealing with a blunt, impenetrable distal cap. And of course, I was also asked to talk about triple lumen catheters, which actually, it's not really triple lumen. It still is only 2 lumen, but 3 exits. So that's just a picture, and I'm happy to talk offline if you have questions about recross. I already talked to you about your angulated microcatheters and, of course, the venture catheter. You also have the Tonus and the Turnpike Gold for calcium. So recross is the new kid in the block. It really can be used both for parallel wire as well as for antegrade dissection reentry. This was the first case actually that I did in India a couple of months ago. RCA CTO, wire subintimal, recross, second wire goes in, and essentially you go. The advantage is that the proximal and the mid holes are 180 degrees apart, so you still cannot get the advantage like you do with Stingray. You can't always tell the orientation, so that makes it a bit challenging. The advantage is that you can perform straw when you're trying to play with the wires. And this is, guys, if you just let me play this is kind of important. It's a quick video. I'll try to kind of cut to the chase. You guys already saw one case of recross. So I'll just tell you here what happens is that the first wire was subintimal. So this is actually from my Insta, so it's just up there. Sorry about the projection. So once your first wire is subintimal, you can just take recross. It's pretty pushable. It comes with a stylet, just like the enhancer. You can take a second one and do it. And actually, instead of showing you a case, what I really want to show you is the very end, where I actually took this recross back to my lab, and I just wanted to show a demo of how it looks. So you can see the wire going out through the 3 holes, which will give you a little bit of an idea. So you can see the one goes there. I think I pulled it back, and then you can take the second wire, it can go through the other side. So you can see that they actually go opposite. The proximal most port and the distal port are the same. So that's the same lumen. So that's basically it. So if you understand what you're asking the microcatheter to do and the properties of the microcatheter, you're going to have better success. I think there are new microcatheters. This is an actively happening area. So use it. Recross could be a game changer. I think lines are increasingly blurred between parallel wire and ADR. And thank you. That's it.
Thank you, Dr. Arun, for your brilliant presentation on microcatheter. We see lots of CT operator in front of us. So we want to hear from your experience using microcatheter. Sir, anyone?
Microcatheter is a wonderful tool for CTO. So far I have failed very less. Usually I can cross with the microcatheter in most of the cases. And sometimes I need to use, I start with floppy wire, and gradually I go for the harder and slippery wires.
Okay, thank you, sir. Thank you, Arun, for your excellent presentation. So, we'll move to the next presenter.
Excuse me.
Doctor, I have a question to our presenter, Dr. Arun.
Yeah,
I have a question to you. Actually, there are various of microcatheters are available in the markets, just like the wire. My question is, which microcatheter is suitable for which type of ablation and which type of that is bifurcation or situ, or what types of lesions and what types of disease process, which one is preferable? Can we explain in a few words?
Yeah, I'll try and summarize that. Actually, I really wanted to talk about that, but the topic I was given was dual lumen and triple, so that's why I did not, because that's an entire talk. But if you look at the nuts and bolts, right, there is no best microcatheter. It's about what you wanted to do. There are the big microcatheters and the small microcatheters, very bluntly put. The Caravel fine cross is what you have in the small category. I believe you guys still don't have Teleflex. We don't have it either, so I'll just stick to the ones that we have. So the ones that are torquable, the Corsair family is always torquable. Torque's a little bit better counterclockwise than clockwise. Don't over-torque it. The tip is pretty soft, but the Corsair Pro, the tip doesn't break. The Corsair XS, the entry profile is a little bit lower, but the shaft, the proximal part, is still the same size. So that's just something for you to keep in mind. The small microcatheters, Caravel and fine cross, are both push catheters. So I mean, you could torque them a little bit, but really don't over torque them. I would be wary of using Caravel in very calcific vessels because it can still get stuck. Fine cross, and the thing is, don't be dogmatic. Say you've crossed a collateral and your Corsair won't go. In fact, in one of the talks, I think I have a talk coming up where it's okay to switch. Like, sometimes a fine cross does what Corsair doesn't, or a Corsair XS might. Sometimes the 135, because the transmission is better, crosses better than the 150. So these are subtle points. In general, never over torque a microcatheter. If you want pushability, and if you want, like, you're talking knuckles push, I would use a bigger catheter. I would use a Corsair Pro. Typically for antegrade, I start off with Corsair because then I can switch to ADR. If it's fine cross, I still have to balloon it, so it saves me one step. If I'm going retrograde, I prefer XS. Epicardials, my choice is probably Caravel.
Thank you.
Thank you.
Yes. Thank you, Dr. Arun. I have a very simple question regarding Caravel and fine cross.
Right.
Which one is more comfortable to you?
Depends. So for epicardial, I really like Caravel because it's just, I think it's probably the microcatheter to beat. Fine cross still is a very good microcatheter, so not to say anything bad about it. One of the advantages with fine cross is if it's calcium, that, I know the tip won't break. So I can be a little bit rougher with it, and I hate using that term. Caravel, I got to baby it a little bit more, but in general, epicardial collaterals I have a clear preference. With septals, I almost always go either Corsair or fine cross. Corsair more so than fine cross.
So in your Caravel, do you rotate it anti-clockwise? Yeah?
So no, Caravel, the textbook answer is you don't rotate. But if you think about it, any microcatheter, when you rotate it a little bit, it does reduce the coefficient of friction, so it makes it a little bit more deliverable. The key is don't overdo it. Just a few here, there is fine. But like I said, if you ask a lot of the purists, they would say, oh, you never torque a Caravel. You can, just within reason.
And other thing, that radio-opaque marker in Caravel is a bit away from the tip of the microcatheter. So sometimes it may produce confusion whether I am up to the lesion or just behind the lesion line.
And that's the thing about Caravel. One, that is true, and also it can break. So just be very, very careful with calcium and Caravel. That's all I would say. And definitely don't over torque it. That's not a catheter that you want to torque too much.
Thank you.